Moving on to the next presentation, may I please invite Dr. Vyjayanthi S, Head of Department and Consultant in Infertility, Reproductive Medicine and Surgery, KIMS Fertility Center, Hyderabad. She'll be presenting on the topic Controlled Ovarian Stimulation, How to Get It Right, Difficult Case Scenarios. Over to you, Doctor.
Good morning, everyone. At the outset, I would like to thank Vyjayanthi sir, my teacher, for very kindly inviting me, and I'm very fortunate to be here for the Advances 25. I've also got Sheila ma'am, she's also my teacher, so I pay my respects to both my teachers here. So today in my talk is on controlled ovarian stimulation, how to get it right. Controlled ovarian stimulation is the first and the most crucial step in the process of IVF. Unless we get this right, the subsequent steps are likely to be compromised. So either under response or over response has got its implications, and so it is very important to get this step right. So based on ovarian reserve markers, we classify women as expected high responders, normal responders, and poor responders. Among these groups, high responders, most of whom are women with PCOS, I consider them as having, very extremely challenging when we look at controlled ovarian stimulation. And for the purpose of my talk today, I'll be focusing on this group. The way I have structured it is, I'll share some case scenarios with you, and then I'll proceed to discuss with the various aspects of the ovarian stimulation. Just a small disclaimer, these are all not cases which I personally managed. I just got it from somewhere to make the discussion interesting. So case 1, Mrs. AB, 35 years, higher age for fertility, higher BMI, hyperandrogenism clinical features she has, high BMH and a high AFC. So she was started on an ANTAC protocol, 150 units fixed dose, and when there was no response on day 6, it was increased to 225 units, and the same units and the same dose was maintained all through stimulation. On the day of the trigger, the E2 was on the higher side, close to 5,000 picogram per ml. GnRH agonist trigger was given and a freeze-all policy employed. So 16 oocytes retrieved, good FERT rate, good number of blastocysts with a good outcome, no OHSs. This is case 2, similar age and BMI borderline high. Again, AFC is high, AMH is very high, 11 nanogram per DL. So again, same ANTAC protocol, starting dose 150 units, and the same dose was maintained. It was not decreased mid stimulation. So on the day of, so quite a lot of exuberant response seen, and on the day of the trigger, the E2 is slightly more than 10,000 picogram per ml. Case 3, again here, similar age is on the higher side, BMI high. Here the AMH is not so high. So the starting dose here was 225 units. Again, the same dose was maintained with no decline mid-stimulation. And again, an exuberant response is seen with an estradiol values close to 10,000. So these 3 cases which I have presented they have shown an exuberant response, whereas this case is more of a resistant responder. Here again, AFC is high, AMH is very high at 15 and BMI of 34. So when the ANTAC protocol was started, 150 units given. When there was no response, it was increased to 225, and a further increase to 300 units was done when there was no response. And when 300 units didn't respond, the cycle was cancelled and restarted with a higher dose of 450. And again, once they responded to the dose, it was brought down to 300, but still it showed an exuberant response. So ovarian response to stimulation is very variable between PCOS patients, and one side we see the high responder, and on the other side we have a resistant responder. But even when we talk about resistant responders, these women, once they start responding, will show an exuberant response, and this is what we see with most of our PCOS patients. Now I'll be presenting the evidence and also the consensus opinions with regards to several aspects of controlled ovarian stimulation in PCOS. The first is what is an ideal stimulation protocol in these women. The second is starting dose. How do we decide the starting dose? Second, do we maintain the dose or we titrate the dose in between if we see a hypo or a hyper response? And the fourth thing is, do any adjuvants modulate the response, what we see with the controlled ovarian stimulation in PCOS women? And finally, we want to avoid a hypo response and again a hyper response on the other side. So the first question, is there an ideal protocol in PCOS women? The 2 commonest protocols we use, agonist and antagonist, and this is the international evidence-based guidelines for the assessment and management of PCOS, the latest one published in 2023. So the recommendations are between agonist and antagonist protocols, there is no difference in efficacy. But for safety reasons, GnRH antagonist is the right protocol of choice for PCOS women, as we get similar responses with almost no chance of hyperstimulation, and the cumulative pregnancy rate is very good. So that between the two, we should be choosing the antagonist protocol as far as PCOS women are concerned, and that is where I'm sure we all are doing these days. Now, moving on to the second question, how to decide on the starting dose? Are we going to go with a fixed dose, or are we going to go with an individualized dose based on age, BMI, and the reserve markers? So this is by far this randomized control trial called the Optimist trial, which was published in 2017, is by far the largest trial which has tried to answer this question: is individualized dose better or standard fixed dose better? This is not just for PCOS women, for other categories too. But when we look at the part 2 of this trial, which is specifically for predicted hyperresponders, the conclusion is that in women who are hyper-responders, which is defined by an AFC of more than 15, the study showed that when they used a lower dose, 100 units, the live birth rate was similar. However, the hypo-response was more when they used the 100 units dose as opposed to the 150 units dose. But having said that, this study also has 3 out of the 4 cases they have with the agonist protocols, and only 1 out of the 4 had the antac protocol. As I mentioned, most of us have now shifted to the antac protocol, particularly in the context of PCOS. Now, this again, a secondary analysis of the same trial carried out, looked into the effect of female age and body weight, because as I said, this trial looked into mainly the response was based on the AFC. So now this is the Optimist trial. The total number of women 1,500, and with predicted hyper-responders, it is close to 500 women were in this trial. So if you see here, the left lower column, it says here lower live birth rate, lower OHSS. So as the age declines, if you are going to decrease the dose, the OHSS risk decreases, but it happens at the cost of a decreasing CPR, clinical pregnancy rate. So even if you have someone with a younger age, you can still use a higher dose to avoid the decrease in the CPR, particularly within the antagonist protocol when we use. Again, this is with regards to BMI. Again, if you see, when the weight increases, again, we see a similar scenario. There is a lower OHSS risk, but it also brings down the clinical pregnancy rate. So this makes a cause for increasing the dose when we have someone with a heavier BMI. So now we have seen the Optimist trial. Now moving on to the next evidence, which is the Cochrane review, which has tried to answer this question, which is individualized dose better or fixed dose better? And the conclusion was that they did not find that tailoring the dose of FSH in any particular ORT population, low, normal, or high responder, did not affect the live birth or ongoing pregnancy rates compared to the fixed dose. So there is no advantage in using the individualized dose, was the conclusion. So moving on to the Escherey guidelines, which is on ovarian stimulation, again trying to answer the same question, fixed dose or individualized dose. Here, if you see, it states that when we use GnRH agonist protocols, it is okay to go with a lower dose because safety is an issue here. But when we are going to use the antag protocols, 150 fixed dose is it's quite fine. That is the conclusion. That is the recommendation from the Escherey guidelines. Now that we have seen the evidence base with regards to the largest trial available, the Cochrane database, and the Escherey guidelines, now I'm moving on to the Delphi consensus. Now here, the consensus statement with regards to what would be the right thing to do in a real life scenario, if you see here, the GnRH agonist again should not be used when we are talking about hyperresponders, and the fixed dose of 150 would do for most of our patients. And if the BMI is going to be more than, if the BMI is going to be high, then we can consider using a higher dose. But the higher dose, the value is not, there is no consensus achieved. So GnRH agonist protocols to be avoided, and if the 150 is a fixed dose, is quite okay to use, and if the BMI is high, then you can consider increasing the dose, was the conclusion. So this is a web-based survey based on how clinicians do their starting doses, apart from what we have seen with regards to evidence. It's quite interesting to note here that 60% of the clinicians chose to go with fixed dose of 150 units of FSH in PCOS patients, but they did consider to reduce if necessary if there was a hyperresponse. And 20% of them chose to go with a higher dose, which is 225. And again, when I show, out of the 4 cases I showed, one had a starting dose of 225, which gave a really exuberant response. So now moving on to the poor response. In PCOS women, do we see poor response or a suboptimal response? As we call it as a Poseidon group 1 and 2. And if we see, what is the pregnancy outcome? So this study, which was recently published in 2024, has exactly trying to look into that. What is the incidence of suboptimal response and poor response in PCOS women, and what is the outcome of pregnancy? So this is a retrospective study, and close to 2,500 PCOS women over a 10-year period participated in this study, and they classified the women according to the Poseidon criteria. This is quite a busy chart, but I just wanted you to focus on the first row here. If you see, in younger women less than 35 years old, 1 in 5 women have either a suboptimal response or a poor response. But when we see women who are more than 35 years old, which are the 2A and 2B, the suboptimal response and poor response, 1 in 4 women we see. So on an average, 1 in 4 or 1 in 5 PCOS women, you will see a suboptimal or a poor response. So when we talk about the clinical pregnancy rate, the subgroup 1A, which is a poor responder in a young woman, poor response in a young woman, the clinical pregnancy rates were less than the non-Poseidon group. But when we look at the other 3 groups, which is the suboptimal response in a young woman, and when in an older woman, which is more than 35, both poor response and the suboptimal response, the clinical pregnancy rate was no different from the non-Poseidon group. So when we come to the cumulative live birth rate, obviously because they are poor responders, it was far less than what we saw. But in a fresh cycle, the clinical pregnancy rates were no different from the good responders. So in patients with PCOS, an unexpected suboptimal response can still yield a fair clinical pregnancy rate in a fresh transfer. Obviously, because of the suboptimal response, we can go with a fresh transfer. Now moving on to monitoring of cycles, serum estradiol and follicular monitoring forms the base of the monitoring when we talk about controlled ovarian stimulation. And this paper, which was again recently published, challenges the way we should be monitoring cycles, because we want IVF to be patient friendly. So when we use intense hormonal monitoring, it can be quite stressful for the patients. Though it might apply with normo on poor responders, in the context of higher responders, we might still have to do close monitoring. So I did my fellowship way back in 2003, that is more than 2 decades ago. Those times we were using agonist protocols quite often, and I still remember are getting quite anxious with the estrogen levels and whether they are doubling every 48 hours. We used to closely monitor like a hawk, and we are also monitoring the follicle numbers and the sizes. So when they reach the criteria for trigger, if the levels were high, we were doing coasting. Of course, now that we have moved to the antagonist protocols, we don't have to endure all this. But in spite of all our efforts, we still saw severe OHSs. And I'm sure the younger generation out here would not see any cases of severe OHSs, as we have now moved on with antagonist protocols, agonist trigger, making it extremely safe for this population. So now when we talk about antagonist protocol, do we have a value of estradiol which is safe for a trigger? As I spoke about in the agonist protocols, when we were treating, we used to consider 2,500, 3,000 as a safe level. But as far as I am aware, I couldn't find in literature what is a safe level to give a trigger with a GnRH agonist. And the cases which I mentioned to you before, the E2 levels were quite high as 10,000 and 11,000. So coasting in an antagonist cycle, is it okay? What is the outcome? We don't have answers for all this. So, but what I have pointed out here is that in the oocyte donor programs, now that we have moved to GnRH agonist trigger, the incidence of hyperstimulation, if we particularly are moderate with the starting doses, we don't see them these days at all, and it is very, very safe for our donors these days. So to avoid complications like OHSs, antagonist protocol over agonist protocol, and use GnRH agonist for a trigger, and do segmented IVF, freeze-all, and vitrification now these days has come up, and with the very high success rates we get with vitrification, we have literally, this has revolutionized the ART practice. And I can say hand on heart, my last case of OHSs was 10 years ago. So segmented IVF for all PCOS women, yes, definitely if there's a hyper response we should do, but we also can consider fresh transfer if the response is moderate to low. Mid-cycle titration of the dose, the evidence, again, Eschere guidelines suggest that there is no need to either increase or decrease the gonadotropin dose. But the evidence, the studies which have contributed to this recommendation, most of them are for poor responders, with just one study coming from a high responder. So now we are moving on. In this instance, there are no studies to assess whether fixed dose or a dose adjustment mid-cycle would help in hyper responders in a GnRH antagonist protocol, because most of these studies we are referring to are still coming from the agonist profile, a few including, the antagonist protocols. So now in a retrospective study, but what happens in real life situation, if you see here in some of the clinics in USA, dose adjustments does happen. It's not just in US, all over the world, dose adjustments does happen, and mostly it is a decreased dose is what we are looking at. Again, referring to the Delphi consensus, here they say, yes, I do decrease the dose mid-stimulation if I see a hyper response, and that is what the majority have come to as a consensus. Now that we have seen what we do with a high responder, let us move on to the resistant responder. So when we talk about AMH, we do know when there is a very high AMH levels like 12, 16, we do know that they are very resistant to ovarian stimulation in an OI setting. How do they respond in an IVF setting? So there is one study which I later discuss about it. Next comes the phenotypes of PCOS. Do they have a different response? Let us look into the evidence related to that. And then FSH receptor polymorphism. What is the effect? And do algorithms still work? Now, this is a study which was published in 2018 looking into the ovarian response in hyper-responders according to the PCOS phenotypes. So just a quick recap of the phenotypes. The phenotype 1 has got all three elements: hyperandrogenism, ovulatory dysfunction, and PCO morphology. Phenotype B doesn't have the PCO morphology. It has got the other two components. Phenotype C is the ovulatory phenotype, and phenotype D has got ovulatory dysfunction and PCO morphology. So when we see here, phenotype A is the very sensitive phenotype. We see greater number of follicles, higher AMH, more incidence of OHSs. Phenotype B, which does not have the PCO morphology, they need greater doses of gonadotropins compared to the other phenotypes. So moving on to the FSH receptor polymorphism and how it affects ovarian stimulation. The cause and effect relationship between FSH receptor polymorphism and hyporesponse has not been established. But according to this study, which was published in 2012, if you use a higher gonadotropin dose, you are able to overcome the resistance which we see when we see a FSH receptor gene polymorphism. Though I have not projected here, it's one of the studies which is coming from CMC Vellore. In that they showed the Poseidon group 1 and 2, particularly when it happens in a normoresponder, when they increase the dose in the second cycle, they could see that there is absolutely no difference in the outcome when they compared it with normoresponders. So it just needs an increase in the dosage. So when we come to AMH, as I said, when they have a higher AMH, they are quite resistant to stimulation. So this study does classify the AMH into the different centiles, but it doesn't say that when they had a higher AMH, whether they had difficulty in stimulation. It just says that though they had more oocytes retrieved, the quality was less, and the live birth rate was far less than the other two centiles. So we need more work on what is based on the AMH, what is the dose we are going to give, and how the response is going to be. Now moving on to the role of AMH or AFC based algorithms in deciding the starting dose. While there are some algorithms taking into account both AMH and AFC when choosing the initial gonadotropin doses, there are no studies on the efficacy of such algorithms in hyperresponder patients. As such, at the moment, it is not recommended to use an algorithm to estimate the starting dose of gonadotropins. AI algorithms. AI now has almost pervaded every aspect of our life, and rightly so here too. So when we talk about AI assisted IVF in deciding the starting dose, this is one of the early studies using the machine learning, and this model, where in a subsequent RCT, was showed that it resulted in a lower number of oocytes when they used the AI based algorithm. This is a more recent study published in 2023. And this is an observational post-market study. This study is the first clinical trial to prospectively evaluate the efficacy of AI for optimizing the starting dose of FSH. So if you look at here, and the conclusion was that there was a non-significant trend towards improved patient outcomes and a reduction in FSH dose when physician used the AI. But still we need a lot more evidence before we say that AI is better than what we currently use. So here, if we see, based on the algorithms, age, BMI, AFC, and AMH, the AI has given the starting doses, as you can see here. So coming on to the pre-IVF medication, most of our women with PCOS have irregular cycles, and to start with a cycle, we need a withdrawal bleed. We do know in an antagonist protocol, COC does reduce the pregnancy chances, so progesterones are better for these women. Coming to metformin role of adjuvants, this is again the PCOS guidelines, international consensus guidelines. It says if you are going to use an agonist protocol, of course you have to start metformin to reduce the risk of OHSS, but this doesn't apply in an antagonist protocol setting. Having said that, for patient safety and with equal efficacy, we would definitely choose antagonist protocols against agonist in a PCOS setting. So talking about alternate protocols, progesterone prime protocols these days are being used in different situations, but when we talk about PCOS women, we don't have strong evidence to say that these protocols are better than the agonist and antagonist which we are currently using. Then minimal stimulation protocol, does it have a role? It doesn't seem to help. And coming to IVM, it is not routine practice. And this, just give me 1 minute, yeah. So now when we talk about IVM, though even in the best of centers, the pregnancy chances with IVM is far less than what we see with a traditional IVF. And this is the reason, and again these days with the GnRH antagonist protocol, agonist trigger, it is very safe and extreme and good cumulative pregnancy rates we are getting. So currently there is no role for IVM in mainstream practice. So to conclude, GnRH antagonist protocol is ideal with regards to both efficacy and safety in high responders. Starting dose on balance of evidence would be to consider 150 units in a patient with average weight, and you can increase the starting dose if the weight is more, though evidence is still not robust. Mid-stimulation dose adjustment, if needed, can be considered to optimize response. Monitoring with ultrasound and serum estradiol levels would help. In case of hyper-response, agonist trigger freeze-all strategy is safer. Pre-treatment with progesterones can be considered. Adjuvants such as metformin can be added in agonist protocols to reduce risk of OHSS. And with regards to AI, we need more evidence, and IVM is not mainstream practice. Thank you.
Thank you so much, ma'am.